So what I will do is to maybe after Professor Sobhi's question about what have you learned from this lecture, is it difficult or not? And most of us said that it was difficult. So I will try to reiterate what Professor Nawar has said in maybe a diagrammatic fashion. So I will not say anything new. Professor Nawar really made it very easy for me to proceed. So again, curable arrhythmias, three of those are the atrioventricular nodal reentrant tachycardia, Wolff-Parkinson-White syndrome, and atrial flutter. So the question now is, why are these arrhythmias completely curable? This is a question that I will try to answer in the end of this lecture. So the first of those is atrioventricular nodal reentrant tachycardia. This is an animation of how it occurs. This is the AV node here. I think this one, okay, this is the AV node. Normally we have only one input for the AV node, which is this fast pathway here. However, in 20% of patients, as Professor Nawar has said, there is another input into the AV node. This is called the slow pathway, which is usually posterior, as we see here. The problem is that you can see here the impulse can go over the slow pathway and then activate the AV node and then re-enter the atrium through the fast pathway and re-excite the atrium and goes back again in this fashion, producing this narrow complex tachycardia as we see here. We can notice that both the ventricle and the atria are activated simultaneously, and therefore you can only see a small retrograde A wave here. It's retrograde, by the way, because the atrial activation proceeds from below upwards, as we can see. So it is retrograde, it's not upright, as opposed to normal sinus rhythm. This is called AV nodal reentrant tachycardia. This is the mechanism in a diagram. So what do we do for this kind of arrhythmia? We introduce a catheter like this one, and we will show an animation of how we introduce this catheter. Its tip can produce radio frequency energy, which can heat the tissue up to 70 degrees centigrade, and it can cause what is called ablation of the tissue, like cauterization. This is an animation. This is the patient lying on the table, and this is the catheter. We introduce it into the femoral vein here. It proceeds up to the inferior vena cava, and this is a cut section of the heart. It goes through the inferior vena cava here, into the right atrium, and this is the AV node, and this is the tachycardia. Fast, slow, fast, slow, fast, slow, like this. And this catheter can deliver energy in a precise position in the slow pathway here. This is the ablation lesion, and what occurs is that the tachycardia is completely abolished. So now we don't have the tachycardia, and we have normal activation from the SE node, both atria, through the fast pathway only into the His bundle branches, and the ventricle. So now we transform this patient from a patient who has dual AV nodal pathways into one of our normal population with only the fast pathway. So why do we do ablation for this patient? It's quite easy. The acute success rate is above 95%, and the recurrence rate is very low. Complication rate, as we can see, is minimal, 0.2, 0.4%, very low. So it is a very safe procedure, very effective, very low recurrence rate, as opposed to antiarrhythmic therapy. So the next arrhythmia is Wolff-Parkinson-White syndrome. Professor Nawar explained it in a very nice way. This is an animation again. Notice here, this is the AV node. There is an accessory pathway here connecting the right ventricle and the right atrium. And so what occurs is that conduction from the SE node, the ventricle, and then through the accessory pathway fast here, it activates most of the ventricle before the AV node can conduct the impulse. And this produces this delta wave here. And then both ventricles are activated by the two pathways. We can continue like this. And then we have a complete activation of all the ventricles, thus finishing the QRS complex. What can occur is that a premature impulse, as Professor Nawar has said, can block in the accessory pathway and only travel through the AV node. And when this occurs, the QRS becomes narrow because it conducts only on the normal pathway. And then it can hear the block, it activates in a normal fashion, it becomes a narrow complex, but it can travel in the retrograde direction from the ventricle to the atrium, and then from the atrium again to the ventricle. And it can cause a continuous or circus loop tachycardia. This is called AV reciprocating tachycardia, as Professor Nawar have said. Okay. Good. So this is very dangerous. An accessory pathway, as Professor Nawar has said, can conduct, can have an atrial fibrillation, and it can conduct through the accessory pathway in a very rapid manner, giving this pre-excited atrial fibrillation. Professor Magdi Badia he asked a question: how can we differentiate this from bundle branch during atrial fibrillation? Really, the answer is simple. First of all, this tachycardia, this atrial fibrillation is very rapid. The ventricular response is above 200 beats per minute, if we can see it. And this should raise a suspicion of an accessory pathway, because the AV node cannot conduct more than 200 beats per minute. If we can see this type of tachycardia, then this is surely a pre-excited atrial fibrillation. It's not atrial fibrillation and left bundle branch block. The other thing is that this patient in sinus rhythm, do we see a delta wave in the normal ECG or not? If we can see a normal a delta wave in the ECG when he is in sinus rhythm, then this is a pre-excited tachycardia again. However, if he has a left bundle branch block in the normal ECG, then this tachycardia would be an atrial fibrillation with left bundle branch block. So, how do we ablate this? It's very easy, like the previous case. We introduce the catheter through the inferior vena cava, and we target this accessory pathway, and we just deliver a single energy here, and we just ablate it. And therefore, the patient becomes a normal individual. Again, success rate is very high, complications are very low, and recurrence is very low. So that's why it's a curable arrhythmia. Atrial flutter is the third one, as Professor Nawar has said. Here, there is a macro re-entry, you can see, around the right atrium, the whole right atrium. Okay, so it is around the tricuspid valve here, like this. And we can notice here, this is the septal leaflet of the tricuspid valve, and this is the rim of the inferior vena cava. The impulse has to travel in this isthmus here. This isthmus, as Professor Nawar has said, is between the inferior vena cava and the septal leaflet of the tricuspid valve. So, this produces the atrial flutter, as we can see. So, if we can really deliver a catheter from the inferior vena cava, and we draw a line of block, not a single point, but a line from the septal leaflet of the tricuspid valve up to the inferior vena cava, then this circuit is completely abolished. It cannot occur. And this is the ablation catheter, and this is the line of block, which is called the cavotricuspid isthmus block. We do it, and we get rid of the arrhythmia in 2 minutes. So acute success is very high, and that's why it's a class 1 indication to ablate atrial flutter with this simple procedure. The fourth curable arrhythmia is not a narrow complex tachycardia, however, it is ventricular tachycardia.
Dear doctor, your time is up.
Yes, 2 minutes. Sure. So, Okay. This is a type of tachycardia which can be cured by catheter ablation also. This is ventricular tachycardia, which arises from the right ventricular outflow tract. And this is a simple procedure. This is actually one of our patients. We introduce the catheter through the inferior vena cava, here the right atrium, right ventricular outflow tract, and we localize the focus here. This is a focal type of tachycardia, and we ablate it quite easily. Okay. And this is the recommendation for ablating this type of tachycardia, which is the right ventricular outflow tract tachycardia. If this patient presents with syncope, or he has a fast VT, or he has short coupled VT with R&T phenomena, or very frequent VPCs. And the success rate for this type of tachycardia is around 90 to 95% of patients, with a recurrence rate is of only 5% as opposed to antiarrhythmic therapy. So, to answer the question, why are these arrhythmias completely curable? First of which, the ablation targets are very well defined electrically. We can really target these electrical signals very good. And also, they are very well defined anatomically. It is as the similar anatomy from every patient to the other makes this procedure very successful. And also, the ablation targets are easily accessible. We can access them, most patients, from a right-sided heart catheterization through the femoral vein with no arterial puncture. And that's why RF, radiofrequency ablation, has emerged as one of the few medical interventions that can offer complete cure from disease states that can significantly impair morbidity and mortality. And I'm fortunate to say that now at the ICC, we have a state-of-the-art EP system from St. Jude Medical, which can really do this job in a very good way. And thank you very much for your attention.